Good afternoon, doctors. Welcome to this webinar on influenza and its prevention. I, Dr. Prashant, on behalf of Hetero Healthcare, welcome you to this webinar. Hetero Healthcare, as you know, our journey began in 1993. We have 30 years of excellence with 300 plus products in our portfolio. We have state-of-art manufacturing facilities, and we are among the largest manufacturers of ARV, API, and FDFs in the world. We have Asia's largest manufacturing at SEZ complex, Visakhapatnam, Andhra Pradesh, and a presence in 125 plus countries. Today, to speak on influenza and its prevention, we have got eminent doctors, Dr. Swati Shruti and Dr. Sainath Powar with us. Dr. Swati Shruti is consulting pediatrician and neonatologist since 1996 at Dattakashi Hospital, Satara. Madam has passed with this distinction, fellowship and diploma in child adolescent disease, passed diploma in child nutrition from Boston University, USA. Madam is director and founder Chirayu Children's Hospital, Satara, and is life member IMA, Indian Association of Pediatricians, National Neonatologist Forum, and Infectious Disease of Pediatrics. Dr. Shruti has served and arranged free camps in and around Satara and has participated in free camps at Lokpetri Prakalpa, Hemal Kasa, Dr. Prakash Amte's Prakalpa, and at SCARCH, Dr. Abhay Bang. Welcome, madam. Welcome, Dr. Shruti. Our next speaker for the evening is Dr. Sainath Powar. Dr. Sainath Powar is MBBS, MD, Pediatrics, DCH, and FCPS. Sir is Fellow in Allergy and Asthma from University Hospital of Leicester, UK. Certified Pediatric Flexible Bronchoscopist by APPS and IIB. Consulting Pediatrician and Pediatric Pulmonologist. Consulting Allergy and Asthma Specialist. Dr. Powar is President, Kolhapur Academy of Pediatrics 2024. National Trainer for ATP IIP Action Plan. National Trainer for Pulmostar IIP Module, National Trainer for IIP REAP Module, Executive Board Member for Maharashtra, Respiratory Chapter of IIP. Welcome, Dr. Powar, and over to you for your deliberations on influenza and its management. You can share your screen, sir. Yeah.
Yes. Am I audible? Hello?
Yes, sir. You're audible, sir.
Audible. Okay. My screen is also visible.
Yes, sir.
Okay. So it is the empiric use of today's topic is empiric use of oseltamivir in flu management, and I welcome Shrutri Madam for being here, and she's a very well experienced pediatrician, well-known pediatrician from Satara. So welcome, Madam. And today we are going to discuss the contents of today's discussion is like healthcare challenges in monsoon and their diagnosis, influenza and its complications, clinical evidence of oseltamivir, guideline recommendation for empiric use of oseltamivir. So, what are the key facts? Basically, there are around billion cases of seasonal influenza annually, including around 3 to 5 million of cases severe illness, and it causes around 2,90,000 to 6,50,000 respiratory death annually. 99% of death in children and under 5 years of age with influenza related low respiratory tract infections, and most of them are in developing countries. The symptom begins in 1 to 4 days after infection and usually lasts around a week. So what are the healthcare challenges during the monsoon? So it is first thing, it is influenza like illness, second is H1N1, third is severe acute respiratory illness, and fourth is COVID-19. So nowadays COVID-19 is not very significant. So dynamics of the occurrence of the influenza in relation to the seasonal variation. This study was done in Chennai, Tamil Nadu, as it was a 7 years cumulative study. And this study was done by Department of Virology in 2019 in King's Institute of Preventive Medicine and Research, and almost 36,670 specimens were subjected to influenza analysis. And the duration of the study was 7 years. And what they found is that influenza positivity started with onset of monsoon and peaks during the post-monsoon months. So this is the overall incidence of influenza. So this first chart is showing the cases and the second chart is showing the deaths due to the influenza. So this is blue box is showing 2015 influenza cases. This red box is showing 2018 cases, which are 15,260, and this green box is showing of 2019, which was almost 28,798. So as the days are progressing, years are progressing, the number of cases of influenza vaccines are progressing. And here the deaths are also progressing. In 2015, it was 299 deaths. In 2018, it was 1128 deaths. And 2018, it was almost 1200, and 2019, it was 1218 deaths. So both the deaths and cases are increasing. So we have to be very alert about this flu. So what are the symptoms of flu? So first is, it is fever, chills, body ache, cough, headache, sore throat, runny nose, stuffy nose, tiredness, that is weakness generally, and diarrhea and vomiting. These are diarrhea, vomiting mainly seen in the children. So these are the general symptoms of the flu. So let's discuss some cases actually. So this is a 2 years old female child admitted with cough since 5 days, which was dry hacking cough, and cold since 4 days, which was running nose, fever since 3 days, which is high grade fever intermittent. The child on examination had heart rate of 125 per minute, respiratory rate of 35 minutes. There was tachypnea was there. On examination, RS examination, there was bilateral Krebs was there, occasional Rankoi were there, and provisional diagnosis was lower respiratory tract infection. And we have done CBC, which was looks to be normal. Only lymphocytosis was there. CRP was normal. Platelet was normal. CRP was mildly raised, that is 9. So normally 6, so it is mildly raised, which we can say normal also. And this was the X-ray which was done for that patient, and which is showing the some hilar haziness with right side hilar haziness above and lower side. So basically we're treating this patient as LRTI. So we started him on antibiotics, nebulization with leosalbutamol. Slowly tachypnea reduced, but on day 3 of admission, patient means though tachypnea was less, the patient has become drowsy. The look was sick look child, and baby was not accepting feeds, not looking well child. So there was something was in our mind that something is going wrong, and why he is not improving in spite of antibiotic nebulization, and though the reports are normal. So we did a H1N1 swab for this patient, and which came positive. And after immediately doing the H1N1 swab, we started the treatment part. That this patient was started on oseltamivir, and then within next 48 hours, patient improved very well. The tachypnea was better, X-ray was better, child sensorium improved, and X-ray was done later actually. So sensorium improved and tachypnea was reduced. So patient become, and patient was afebrile also. So basically patient improved on starting oseltamivir. So this was the first case. So whenever we are seeing the patient in day-to-day OPD, generally we sorry. So madam, do you want to add anything in this case?
No, no.
Okay. Anything you want to give any message or something? Okay.
No,
So
it's all right.
basically from this, yeah. So basically from this case, what we have to learn that whenever we are seeing a case of LRTI, and especially this child is around 1 or 2 years, and if they are becoming drowsy in spite of normal reports, CRP is normal, CBC is normal, so then this was a clue that this is a maybe going towards viral etiology, and viral specifically H1N1. Only viral etiology will not cause drowsiness, but H1N1 may cause drowsiness. So that was the first clue. And whenever we are seeing many patients in OPD, so we have to always differentiate between viral and bacterial. So whenever we are getting respiratory symptoms like cough, cold, maybe sometimes fever plus minus. So onset is like acute. In viral, it is generally acute, more gradual than bacterial. And family history of similar cases may be there. So there may be viral in other family members also. In bacterial, generally it is high grade to start with, and generally patient is toxic actually. And in viral, the cough is predominant symptoms, and in bacterial, generally not very significant cough is seen. Cervical lymphadenopathy less likely in viral, and if that is means the infection is with the upper airway or tonsil, you may get a tender cervical lymphadenopathy in bacterial infection. So associated symptom in viral like rhinorrhea, exanthema, hoarseness of voice, uh, frequent diarrhea plus minus, so conjunctivitis. So multi-system affection more goes in favor of viral infection. So localized infection without coryza, absence of nasal symptoms goes in favor of bacterial infection. So local examination, you may see the red pharynx, but in bacterial infection, you may see tonsillitis, you may see the thick exudate, purulent patchy tonsils. So these are the how you can differentiate between viral and bacterial thing. So we are going to see the another case. First case we have seen 1 or 2 year child. Now we are seeing a 14 years old boy with no underlying comorbid condition. He was referred to our hospital and he had a fever of low grade fever, sore throat, myalgia for 7 days. There was no history of breathlessness, vomiting, or diarrhea. Before, when seen previous admission, before wherever he was, he has received antibiotics in the form of ceftriaxone and piperacillin tazobactam. But there was no significant improvement. So basically, on examination in vital, pulse was 110 per minute, BP of 110 by 72 millimeters of mercury, temperature of 100. When we examined the child was having bronchial breathing, bilateral core crackles, and mainly in the inframammillary region. So there was a mid-zone interstitial infiltrates on the chest radiograph, X-ray chest. And then seeing all these things, the nasopharyngeal swab was taken and PCR was done, which was positive for H1N1. CRP was normal, like it was 10 actually. Rest other system examination were normal and CBC were normal. CRP was also normal. LFT was also normal. This was the X-ray. So which is showing a bilateral infiltration, maybe hilar and peripheral area also. So as the H1N1 was positive and patient was not responding to the antibiotics, we have started him on oseltamivir and paracetamol was also given oral hydration. And this patient was as admitted, IV hydration was also given. He was counseled about hand washing and everything. And patient showed a marked improvement in his symptoms. His tachypnea reduced. His X-ray after few days was better. And clinically also fever was, he was febrile and patient improved well. So let us, madam, do you want to add anything in this case?
No, it is nice, no problem. Just please explain to others that what is walking pneumonia. It is mentioned
Ah,
on the top
so
of the
basically,
slide.
in sometimes, so basically, what happens? Ki patient has got pneumonia and patient is relatively stable. So X-ray is bad, but patient is not bad. So the another thing we will think of like atypical pneumonia, and then another this is a walking pneumonia. One of the causes is H1N1. The patient is
Yes.
relatively stable, but X-ray is bad.
In a
Okay.
typical patient is toxic. In this patient is not that
Yeah,
much
and
toxic.
X-ray reports are normal. Yeah.
Yes. Yes.
So vice versa, basically. Yes. So in influenza, let's have some look at influenza virus per se. So virus and the influenza disease, it is the one of the most common infectious disease caused by influenza virus. It is influenza or flu. It is highly contagious airborne diseases that occurs in seasonal epidemics and manifest as an acute febrile illness. So it can cause mild to severe illness. A serious outcome of flu infection can result in hospitalization and death. And this is the anatomy of the this virus, influenza virus. And depending on the there are two surface proteins, hemagglutinin and neuraminidase. And depending on this H and N, there are various mutations of these viruses. And so it is labeled as H1N1, H2N2, H3N5, and all those things. So which are the currently mutations which are there in the community. These are H1N1 and H3N2. So again, types of influenza viruses: type influenza A, which is causing epidemics due to the minor antigenic variations or mutations, or periodic pandemics due to the major antigenic variations. And it goes on, the mutation goes on there every year or 1 or 2 years, and these strains goes on changing. So we have to change the basically that is more important for vaccines actually, because they have to change the strains of that vaccines. Influenza B viruses, it infects only humans, it causes local epidemics. Influenza C virus infects humans and swine. Influenza type C infection are generally mild respiratory illness and not thought to cause epidemics. So transmission, so basically people with flu can spread it to the others if it is in between 6 feet distance. So flu viruses are spread mainly by droplets made by people with flu. When they cough, when they sneeze, when they talk, their droplets actually comes in the air, and it if the another person is within 6 feet, he can catch that infection. So the people should stay away from the actually ill person, and we should advise all the children and all the patients that if they are not well, if they have got influenza, they should stay at home, because if they go out in the school or in the office, they may spread the infections. And it is very important that whenever there is a one in family member is affected, then all the members and patient also should make a good hand washing. So good hand washing technique is very, very important. And whenever the patient is getting infection, so he is able to infect other people 1 day before the symptoms and 7 days after the symptoms, actually means when he has become the sick. And children may this virus for longer time, maybe more than 7 days also. So now we are differentiating in between influenza like illness, H1N1, severe acute respiratory illness, and COVID-19. So the most of the symptoms like fever, myalgia, cough, lack of energy, sore throat, these all symptoms are more or less there in all these four. Breathlessness is more in influenza, less in the influenza-like virus. It may be there in H1N1, SARI, and COVID-19. So breathlessness is there. So these three are more important. Loss of smell, loss of taste is a characteristic of COVID-19. So we have to think of COVID-19. Diarrhea generally seen in, along with COVID-19. Sometimes we may get into influenza-like illness also. Headache may or may not be there in influenza. Then influenza-like illness, H1N1, generally it is there. In SARI, it may or may not be there. And COVID-19, sometime it is there. So these are the differentiating point. It is very overlapping, but just it will help us to differentiate at to few extent. So this is what are the emergency signs in children? Warning signs of flu sickness. So in children, if there is a fast breathing or tachypnea, bluish skin म्हणजे cyanosis, if the child is not able to take the fluids or is not able to take the food, the child is not waking up, not interacting, that is sensorium is deteriorating, child is very much irritable and he doesn't want to be held. Flu-like symptoms, initially it has improved, but again returned with fever and worse cough. So these are the warning sign, and fever with rash. So these are the warning signs. If these signs are there, we have to keep watch on those patients, and some of them may require hospitalization also. So when we are dealing with the flu with infants, then there we have to think of see the other signs like being unable to eat, uh, tachypnea, difficult breathing, and if he has got dehydrated, there will be no tears while crying, and the urine output will be reduced. So what are the complications of flu, like pneumonia, bronchitis, ear infection, worsening of the if the patient has got asthma and he gets flu, then his asthma COPD can worsen. Some of the patient can go to the acute respiratory distress syndrome, ARDS, they can go, and some of the patient can cause death also. So we have to be very alert about all complications. So in general patients, so there are the routine patient, and there are few patients who are got more risk of, I mean, if they get the flu, they have got chances of complications are more. So who are those patients? So first thing is like asthma allergy patient, because most of the asthma attacks are aggravated by viral infection like flu-like illness. Generally, a routine patient may be improved in 3 to 5 days, but asthma patient may get asthma attack and he may having all the other complications of asthma attack. So whenever there is a chronic liver, kidney, and neurological diseases, they are more prone for complications. Juvenile diabetes is the one of the thing that they are more prone for complications. Immunocompromised patient from maybe HIV, AIDS, cancer, immunosuppressive medicines, they are more prone for complications. Sickle cell disease, obesity, and if the children who are there for long time, they are be in healthcare facilities, uh, children care facilities, they are there, so they can have more complications. So management of influenza now. So first treatment is always supportive treatment like bed rest, take ample of fluid, oral fluid hydration, if required IV hydration. If there is a irritating dry cough, then we can give cough suppressant. Antipyretics like paracetamol can be used. NSAID if there is a very fever or myalgia, but generally we should avoid NSAID as far as possible. Most patients with influenza recover within 3 days. However, sometimes malaise may persist for weeks. Severe cases may require IV hydration, as we have spoken, and other supportive management. So when we are talking about antiviral drugs in a influenza virus, so there is a neuraminidase inhibitors and adamantins, that is M2 channel blockers. So in neuraminidase inhibitors are they block the viral neuraminidase enzyme, which is critical in the releasing virons from the infected host cells. And these drugs are active against influenza A and B. The examples are oseltamivir and zanamivir. And the other group, they interfere with hydrogen ion channel activity of the influenza virus, thus blocking its entry into host cells. It active against only influenza viruses, and the examples are amantadine and rimantadine. So, what is the most important thing that we know that we are using oseltamivir only for routine patients. So let's learn more about oseltamivir. So it is a potent and selective inhibitor of the neuraminidase enzyme of the influenza virus A and B. Oseltamivir is prodrug which is converted to the active form, that is oseltamivir carboxylase in the liver. It inhibits influenza virus replication and its pathogenicity. It prevents further spread of the infection. It is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1, and H9N2 strain. So here what happens actually, these are the neuraminidase inhibitors. They will block the virions sites so that no virion will be released, and they will halt the viral replication. So oseltamivir, it was the first oral neuraminidase inhibitor. Oseltamivir is approved more than 100 countries. FDA, CDC, American Academy of Pediatrics has approved oseltamivir in the treatment of children for flu vaccine. So basically, what are the doses then? First thing we'll see that we are doing the treatment part. So if you want to do treatment, adults, the dose is 75 milligram capsule twice daily. In children, depending on the weight, if it is less than 15 kg, it is 60 milligram per day divided into two doses. If 15 to 23 kg, 90 milligram per day divided into two doses. 23 to 40 weight, 120 milligram per day divided into two doses. And above 40, we can go for adult dose, that is 75 milligram BD. And in head, there is a 130 milligram capsule is also available. So those children who are able to, they can, if they can take the capsule directly. So here 30 milligram capsule can be used. Those who are not able to accept the capsule, we can use 30 milligram capsule twice a day, or depending on the dose, we can use that capsule also. And it is available only with heteron. So the treatment of with oseltamivir should be initiated within 48 hours of the onset of the symptom. That is a very important thing. Whenever you are thinking of H1N1 infection, you please start oseltamivir as early as possible, preferably within 24 hours. But if the it is already late, so that doesn't mean that you don't start it. You start, the effect will be little less, but you start it and give the benefit of the doubt to that patient. Second thing is whenever you're giving oseltamivir for chemoprophylaxis, then what is the dose? The chemoprophylaxis is recommended for 10 days. In adult, it is 75 milligram OD. In less than 15 kg, it is 30 milligram OD. 15 to 23, 45 milligram OD. 23 to 40, 60 milligram OD. And more than 40, 75 milligram OD. So this is the doses for prophylaxis, chemoprophylaxis. So the recommended duration of the post-exposure prophylaxis is 10 days, and the recommendation duration for community outbreak, seasonal, maybe seasonal or pre-exposure prophylaxis is up to 6 weeks. And a maximum it can be go into 12 for 12 weeks in immunocompromised patients. So what is the benefit of empiric and early use of oseltamivir? So basically, oseltamivir treatment of influenza illness reduce the uh, respiratory tract complications or symptoms, antibiotic use, and hospitalization. So basically, there was a prospective study which was done, which has shown that in the patient with influenza, oseltamivir treatment has reduced the antibiotic use by 26.7%, influenza-related respiratory tract complaints resulting in antibiotic therapy by 55% and hospitalization by 59%. So there is a significant reduction in all of these three. So reduction occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. As we have already discussed, better it should go before 48 hours. So there was a retrospective study was done in 442 patients, and the median time from symptom onset to oseltamivir administration was 5 days. So they are divided into 4 groups depending on the administration of the oseltamivir, that is less than early 48 hours, 3 to 7 days, 8 to 14 days, and more than 14 days. So what was found that both the probability of any severity of the pneumonia and the probability of the severe pneumonia increased gradually with the time from symptom onset to oseltamivir administration. So if you administered oseltamivir early, the pneumonia and severe pneumonia will be less. And earlier, again, the same thing. Earlier, initiation of the oseltamivir administration after symptoms onset significantly reduced the occurrence and severity of the pneumonia, and it also shortened the hospitalization period. So when
Please,
even when administered,
yes, please tell when chemoprophylaxis should be given. What are the indications for chemoprophylaxis? In first,
this slide you are talking about.
this chemoprophylaxis. Should there be anyone positive, documented positive in the family or in epidemics when there is outbreak?
Pre-exposure, that is with the family member.
Yes.
And second is maybe a seasonal also we can out if there is a community outbreak.
Outbreak in the.
That may be this. Yeah.
Yes. Yes.
Okay.
Thank you.
So basically, a patient with shorter time to oseltamivir administration were discharged earlier from the hospital. So if you start early, the patient will recover early. So there was one study which has done that oseltamivir azithromycin combination therapy. So this is to mainly to prevent the secondary bacterial infection. So there was 227 patients who has received oseltamivir and azithromycin, and 102 patient who has received oseltamivir for 3 to 5 days. So what was the result here? You can see that key incidence of bacterial infection where significantly the oseltamivir and azithromycin combined treatment offered significant reduction in the incidence of the secondary bacterial infection and required less respiratory supports. So these are you can see here, and again this is showing that if you are using oseltamivir azithromycin combination therapy, the hospital stay is significantly reduced and influenza symptom severity score is also significantly reduced. So guideline recommendation. So WHO recommendation, empiric treatment is strongly recommended when you are strongly suspecting the H1N1 infection. Treatment should be started as early as possible, best within 48 hours. laboratory confirmation of the influenza virus is not necessary for the starting of the treatment. If it is not available, if you are in periphery, if you are in strongly suspecting, please start the treatment. Negative laboratory test for H1N1 does not exclude the diagnosis. So if your clinical judgment is saying that you are suspecting H1N1 and sometimes the lab report may be negative, still you are justified to continue this treatment. Then if higher risk individual have been exposed to the patient with influenza, so you can consider the presumptive treatment with oseltamivir. So early empiric supportive therapy and monitoring. So give empirically antimicrobial antibiotics to treat all likely pathogen causing SARI. Empiric antibiotic treatment should be based on the clinical diagnosis, that is community acquired pneumonia, healthcare associated pneumonia, and the infection was acquired, whether the infection has acquired in healthcare setting or whether there is a sepsis. So empirical therapy includes this oseltamivir for influenza, and depending on our experience, we can start on the another antibiotic for bacterial this. And you should also include the travel history and exposure to the animal influenza viruses when you are treating with the empirical oseltamivir. So what is the summary? That proper diagnosis can and early treatment can prevent the flu complications. Empiric use of oseltamivir reduce the lower respiratory tract complications, hospitalization, and antibiotic use. WHO, American Thoracic Society, recommends empiric use of oseltamivir. Thank you. Any questions? Madam? Do you want to add anything? Your experience, madam?
Yes, madam. What is your experience on oseltamivir? You're mute, madam.
Madam, your voice, please unmute.
Madam,
It is good drug with relief from symptoms within 24 hours, and patient is satisfied with the relief of symptoms. And as the patient is not toxic, usually on OPD basis also, if I give oseltamivir, then patient doesn't have to come back again for follow-up. It becomes patient cures.
It's generally preferred as a prophylaxis. No? It's generally preferred for prophylaxis, even in adults.
Yes, yes.
And I suppose if you use it prophylaxis correctly or commonly, the incidence of secondary complications of bacterial infections would be much less, I suppose.
Yes. Prophylaxis with low dose also, then
Yes.
the disease doesn't progress.
And maybe patients who are more prone for severe respiratory infections, like immunocompromised patients or patients with diabetes or other things, this type of drug would, I suppose, additionally benefit them, prevent them from going into complications.
Yes.
Respiratory complications, especially.
Even congenital heart disease patients are indicated for chemoprophylaxis when in flu season, when there is outbreak of flu symptoms.
That is correct. Have you seen any treatment
failure? Immunocompromised patients.
Yes. Have you seen any failure with this type of drug? In the sense, use for prophylaxis doesn't really.
No,
so it has worked almost in all patients.
It has worked.
Almost all patients. That's good. And then it should be more commonly. And also, earlier times, flu was restricted to a particular season. Nowadays, you get flu, I suppose, all around the year. Yes, all around the year. In Mumbai, it's very hot currently, but at other places, it's still raining. And we may not know. We may have a wet Diwali also.
Yes. In Kolhapur also, there is a significant rain actually. So
yes, correct.
We don't know.
Which is why the whole viral profile is also changing. Yeah. And at that side, the virus is also changing its protein structure. So possibly
there is no classical season like previously, like July, August. Now this year, July, August, there was no. It has not started. It started later actually.
It started late after in mid-September and later.
And there is no textbook type of presentation these days. And I suppose, I do not, I may be wrong, but I suppose the flu presentations could vary even in India. Maybe in the cities it could be different, in the interiors it could be different. Even for the matter in Mumbai it could be different, and Kolhapur it could be different.
Yes, yes, yes.
It's quite
In
possible.
fact, any patient who is sometimes we see a critical patient and who is not responding to treatment means generally, ideally should not go to that level. But sometimes we see that critical patient who is on ventilator and then we start on fluid and then they respond to it. I saw this also happens actually.
Correct.
Geographic variation will affect the
Absolutely.
symptoms because if it
Correct.
is the humidity, it depends on humidity. So geographic change will affect the symptoms.
And Mumbai humidity is large, we have only 2 seasons, I was saying, in Mumbai, hot and hotter. Yeah. And earlier time it was said that virus would flourish in winter, but now I suppose even in summer they flourish. Maybe. Anyway, thank you very much, madam. Thank you, Dr.
Thank
Pawar.
you.
Thank you, madam.
Yes,
Thank you,
Yeah,
sir.
yes, thank you.
I thank
Thank
all
you,
the
madam. Thank you, sir.
participating doctors who took time from their schedule and attended this. Thank you, marketing team Hitro, for conceptualizing this program. Thank you, field people Hitro, for making this possible. And last but not the least, thank you, IT team. Thanks, Giridhar, for super coordination and support. Thank you. Thanks, all of you. Wish you a very pleasant evening. Signing off.
Thank you. Thank you.
Thank you. Thank you, doctor.
Thank you, sir. Thank you, madam.